and then we will be doing conjunctiva. Okay, guys. So Vijay, Mitul, Shubhaji, Jay, Kashif, Gautam, Mohan, Mitvi, Sambit, Sanket, Ajay, Paul, MD, Shlok, Arga, Asita, Jinal. Oh, okay, everybody. Thank you for joining us, guys. And let's start with our topic, eyelids. Right. This is our second last session, everybody. As you would have seen the schedule in this month, that is May. We are about to complete our complete course on ophthalmology. There are total 27 sessions or 27 lessons, and we are at our lesson 26. Okay. So eyelids. Now, okay, guys. What do we know about eyelids? We know that there are two eyelids, upper eyelid, lower eyelid, right? I know I'm joking. But in eyelids, what do we want to know? Anatomy. Yes, we want to know the anatomy. If you are a third year student, guys, obviously I won't be drawing that diagram. I'll just be posting a photograph of that. If any one of you is a third year student sitting here, then in third year, usually you get a long question, draw the cut section diagram of an eyelid. I'm not going to draw it for you. I'm just going to break that or dissect that into simple points for you. And I'm just going to write it. So if we simply dissect eyelids into anatomical dissection, if you say, we find out that there are three muscles in the eyelid and there are three glands in the eyelid. Okay. So first of all, let us discuss what are the three muscles in the eyelid. Okay. Now, the three muscles in the eyelid. Number one, LPS, levator palpebrae superioris. Number two, Mueller's muscle, Mullers, Mueller's muscle. Mueller's muscle is also known as tarsal muscle. Tarsal muscle, guys. So, and then the third muscle, everybody, is your orbicularis oculi. The third muscle is orbicularis oculi. Okay. So let's see what are the nerve supplies of each, everybody. LPS, Mueller's, and orbicularis. We should know LPS. We have studied it in third cranial nerve palsy, that all the extraocular muscles are supplied by the third nerve except SO4-LR6. And if you remember, LPS is also counted as an extraocular muscle. Whereas Mueller's muscle, if you remember, was being paralyzed in Horner syndrome. Yes, first class, everybody is sympathetic. Horner syndrome, if it was being paralyzed in Horner syndrome, that means the nerve supply was sympathetic. And orbicularis oculi, again, all this we have discussed somewhere or the other. Corneal blink reflex. Corneal blink reflex. If you touch the cornea, fifth nerve goes, then seventh nerve comes to the eyelid in which muscle? Orbicularis oculi. Yes. Now, what are the actions, everybody? So the actions of the first two muscles are the same. They elevate upper eyelid. They elevate upper eyelid. But what is the action of orbicularis? Orbicularis is used for blinking. Blinking means it is basically used for closing the eyelid or eyelid closure. Yes. So in cases of palsy, everybody, in case of palsy of both the muscles, LPS and Mueller's muscle, you will land up in ptosis. But if there is palsy of orbicularis oculi, that means eyelid will not be able to close. So like I had told you in lesson 1 of this course, it will lead to lag ophthalmos. I'll just write it in a clear way. It will lead to lag ophthalmos. Writing it here again, lag ophthalmos. I hope I'm very clear. So lag ophthalmos means inability to close the eyelids. The muscles, the nerve supplies, the actions, and based on the actions, what will the clinical feature be on paralysis? Please remember LPS and Mueller's muscle. LPS is supplied by third nerve, which is parasympathetic, but Mueller's muscle is supplied by sympathetic. That is why in cases of Horner syndrome, ptosis occurs, but not due to paralysis of LPS, due to paralysis of Mueller's muscle. Yes, so I hope you will remember this. Okay, so these are the three muscles. Now, if you look further into the anatomy, apart from the three muscles, everybody understands this? Everybody understands this? Muscle simple, everybody? Okay? Nobody? You understand? No? Yes? So, okay, I think you understand. Okay, I hope you understand. Apart from the three muscles, there are three glands, everybody. Three glands in the eyelid. So, what are the three glands? I hope again that you know the names of. Number one gland is called as meibomian gland. Meibomian gland is also called as tarsal gland. The second gland is your Zeiss gland. And your third gland is gland of Moll or Moll gland. Okay, everybody? Now, everybody. What are the secretions by these glands? Meibomian and Zeiss both are modified sebaceous glands, whereas Moll is a modified sweat gland. Okay, everybody. So Meibomian and Zeiss are modified sebaceous glands, whereas Moll is modified sweat gland. Okay, everybody. Now, where do these ducts open? Where do the ducts of these glands open, everybody? Okay. So opening of ducts, I will say. Opening of ducts. Opening of ducts of Meibomian gland, everybody. Number one gland, Meibomian gland, is just anterior to posterior margin of eyelids. Anterior to posterior margin of eyelids. I'll show you a diagram in which you will be able to understand this. Don't worry. But just remember, anterior to posterior margin. So if this is my upper eyelid, everybody. Okay, this is my eyeball, this is my upper eyelid. This is the anterior margin, this is the posterior margin. So somewhere here, anterior to posterior margin of eyelids. Zeiss gland opens in the lash follicles. So the point where your eyelashes come out from, the Zeiss gland will open right at the base of the eyelashes. And Moll gland opens into ducts of Zeiss gland. Okay, do you understand it? So it does not have a specific opening. So the Moll gland will open into the Zeiss gland, and then the Zeiss gland obviously is opening at the base of the lash follicles, eyelashes, base of eyelashes. Am I clear about this simple fact here, everybody? I will be using all these points that I'm telling you when I'm explaining you the pathologies of the eyelashes or the eyelids. Am I clear, everybody? Are we clear about this? I hope we are, everybody. Now, there is something called the gray line, everybody. In the eyelids, there is something called the gray line. What is the gray line, everybody? Gray line. Please remember this. This is a surgical landmark for us. Gray line. Gray line divides the eyelid into anterior lamina or anterior portion and posterior lamina. Okay, anterior lamina is what, everybody? Anterior lamina comprises of the skin that you see, everybody. Anteriorly, this is the skin, yes or no? Skin of the eyelids and muscles. So after the skins and the muscles comes your gray line, and posteriorly, posterior to gray line, posterior lamina, comes your tarsal plate and conjunctiva. I hope you understand this. If I show you the inner surface of the eyelids, everybody, yes, see my inner surface of the eyelid. What is there, everybody? Conjunctiva. So anteriorly there is skin, posteriorly there is conjunctiva. Am I clear? And in between these two laminas, anterior and posterior lamina, there is something called as the gray line. Okay, everybody. Now, what is the significance of gray line? Surgical significance. Surgical significance is that in surgery, if required, if I need to do some eyelid surgery and I need to cut or open the eyelid, everybody, in surgery, splitting of eyelid is always done at gray line. Please remember. So if I need to split the eyelid into anterior and posterior part, I will search the gray line and then I will split it into these two parts. Okay, everybody. So just simple surgical significance. I hope you will understand this. Then tarsal plate, everybody. Everything else you understand here. You understand what is skin, what is conjunctiva, what is muscle. What is a tarsal plate? What is tarsal plate? Tarsal plate is nothing but it is a plate or a structure which is formed by dense connective tissue. Please remember, it is formed by dense connective tissue. Okay, everybody. It gives firmness to the eyelids. Eyelid firm है ना, ऐसा नहीं है बिल्कुल soft है. Yes. So it gives firmness to eyelids. So a question was recently, I think 2 years back, 2018 or 19, I don't remember, was asked in PGI Chandigarh on tarsal plate. Everybody, it was a very simple question that was nothing difficult, just certain points which you need to remember, that it is a posterior part, it is connective tissue, not fibrous tissue, it gives firmness to the eyelids and such. Okay, now I will bring up a cut section of the eyelid, and through that I will try to explain you these simple points that I've just explained to you here. Okay. Okay, so everybody, you can see the cut section of the eyelid. This is the anterior part and this is the posterior part. So first of all, everybody, let's see everybody, gland of Zeiss. Can you see this gland of Zeiss where my pointer is moving? Do you see it is opening at the lash follicle, eyelashes, you see, everybody? Then you can see the gland of Moll, everybody. Yes, the gland of Moll is opening into the ducts of the gland of Zeiss, and thus it is also at the lash follicle, as I said. But if you see this, everybody, this area that I am just doing blue color, everybody, this area, everybody, all this area, if you can see carefully, this is called your tarsal plate, everybody. Within the tarsal plate is present which gland, everybody? Meibomian gland. So where is Meibomian gland opening? Here, everybody. This is what, everybody? Posterior margin. Yes. So do you understand, everybody, where does Meibomian gland open? Am I clear, everybody? So Meibomian gland opens anterior to the posterior margin. Am I clear, everybody? Anterior to the posterior margin, whereas gland of Zeiss and gland of Moll open in the lashes or the base of the eyelash follicle. I hope everything is clear here. You can see anteriorly there is skin and there are all the muscles. You will be able to see the levator aponeurosis. You will be able to see the orbicularis oculi and all these muscles here. Am I clear, everybody? I hope we are clear about this. So this is just a simple cut section diagram of your eyelid. If you're a third year student, again, just learn how to draw it. Otherwise, you don't need to think about this diagram at all. Okay. So that's a little bit about the anatomy of your eyelids. Now, moving on. If I move on, let me discuss the pathologies in eyelid. Pathologies in eyelid. Okay, everybody. So there are two important pathologies in eyelid which are very commonly asked to students, whether you are a third year student or if you are even in post graduation, they are asked infrequently. Or if you are a clinician, if you are an intern or a JR, then you should know this. You should be able to treat these two conditions yourself. What are the two important conditions, everybody? The first condition is called as chalazion, and the second condition is called as stye. I'm just using the simple word that you should know of, stye. So chalazion and stye. What is the difference between chalazion and stye? First of all, what is different is the type of inflammation. Both of these are inflammatory conditions of the eyelid, chalazion and stye. Chalazion has which type of inflammation? There is one word we look at. This is the one word we want to look at. Lipogranulomatous. Lipogranulomatous inflammation. Then the second question is which gland is inflamed? Meibomian, Zeiss or Moll? Anybody can tell me. So option A, Meibomian, option B, Zeiss, option C, Moll. In chalazion, which of the following glands is affected? Lipogranulomatous inflammation of this should be a very, very ridiculously easy question for all of you guys. Okay, so Arga, Samvit, Mitul, Jinal, 4 have got it right, but 2 have got it wrong. Surprising. 5 have got it right. Hasita has also got it right. 5 are correct, but 4 are wrong. Lots of students here. I will ask all of you to answer, everybody. Vijay is also right. Subhajit, Jay, Kashif, Gautam, Mohan, Sanket, Paul, Shloka. Everybody try to answer this question. This is a very easy question. Meet, Naveen. Okay. Seemingly only 6 of you were right. Arga, Samvit, Mitul, Jinal, Hasita, and Vijay. And 5 of you are wrong. I am surprised to say the least, everybody. This should have been known by all of you. This is too simple question not to know and get it wrong, guys. Meibomian gland. So these are the two questions that they ask you. Which type of inflammation? Lipogranulomatous. Which type of gland? Meibomian. Okay. I don't think you will forget this. I don't think you will forget this. But if you are a student who has a forgetful tendency, then you can remember it by chalazion, Meibomian gland, lipogranulomatous inflammation. CML, chronic myeloid leukemia. This is how you can remember it. CML, chalazion, Meibomian gland, lipogranulomatous inflammation. CML. Never forget it. If you remember this, then you will also be able to remember the differences. Stye is which type of inflammation? So stye is a suppurative inflammation, everybody. Suppurative or suppurative, whichever way you want to pronounce it. Of which gland? Again, the options are the same, A, B, or C. Suppurative inflammation of which gland, everybody? Suppurative inflammation of which gland? I am waiting, everybody. Okay, I'm again surprised that I'm getting mixed answers here. I'm again getting mixed answers. Jinal, Sambit, Kashif, Arda, Shloka, and Mitvi, and Hasitha. 7 of you are correct, and 6 of you are wrong. That's the ratio right now. That's the ratio right now. Okay, so it seems like this is also seemingly an unread topic by a lot of you. So the answer here is Zeiss gland. Okay, now these are the two differences, everybody. The inflammation is suppurative and the gland is Zeiss. Okay, everybody. So please remember this. There should be no confusion about this. Please remember these two basic points about each of the two conditions. Now, as soon as I focus on the word suppurative, what do I understand from the word suppurative? Suppurative means collection of pus. Pus is denoting that sty is which kind of condition, everybody? It is an infective condition. But lipogranulomatous is somewhere telling me that it is a non-infective condition. Okay. So if you remember words, you answer questions yourself. If it is an infective condition, obviously they will ask you which bacteria is most commonly implicated in the causation. So the most common bacteria implicated in the causation is Staphylococcus aureus, your favorite bacteria, guys. Okay. Now, as soon as I write this, because I've written infective, non-infective, I will ask you the treatment. So everybody, anybody whose typing is enabled, everybody whose chat box typing is enabled, can you tell me what is the treatment of sty? It is an infective condition. I told you the bacteria also. What should be the treatment? What should be the treatment? What should be the first treatment you should give? Would you give antibiotics? Yes or no as the first treatment? Would you give antibiotics as the first treatment? Yes or no? Antibiotics as the first main treatment? Yes or no? Infective condition, Staphylococcus aureus. Antibiotics first treatment? Yes or no? Antibiotics first treatment? Yes or no? Mohan Sai Reddy has written yes. 83% of you have said yes. 79% of you have now said yes. 21% have said no. Who is right? Majority. Let's go with the majority. No, guys, majority is wrong in this case. The antibiotics are not the first line treatment. The first line treatment is simply hot compression or hot compresses. All of us have done this in our childhood. All of us have had sty somewhere in our childhood if we have grown up in India, guys. So what our mothers used to do, एक गरम कपड़ा गरम पानी का लेते थे and then we used to compress it. गरम पानी का सेक करते थे. It's almost a self-limited condition. गरम पानी का सेक. इसलिए we do hot compression to reduce the symptoms. That's all. It's inflammation, so there will be pain and blah and blah. Okay. But yes, antibiotics should be given in clinical practice. So we do give antibiotics also. Usually we give systemic antibiotics if recurrent. If it is happening again and again, if you're getting a patient who's having it again and again, then you will give systemic antibiotics. Okay, so antibiotics you're just giving for preventing superadded infection. It is not necessary to give in cases of sty. Please remember. Now, what is the treatment of chalazion? Chalazion is non-infective, so the antibiotics obviously do not matter. So what should we do, everybody? We do incision and drainage. We do incision and drainage. Now, what do we understand by these words? Incision and drainage. Incision, that means we incise. Where do we give the incision and what type of incision? Is the incision given vertically or horizontally? So the first point is that the incision is given vertically. And secondly, where is the incision given? What do I mean by where the incision is given? Everybody, I'll go back to the back page. This is the anterior surface. This is the skin. Will I give incision on the skin or will I give incision on the conjunctiva, posterior surface? Think about it. If I give an incision here, everybody, it will lead to formation of scar, cosmetic blemish. So what do? Is we invert the eyelid, ulta karte hain, and then we incise the conjunctiva. Am I clear, everybody? So the incision is given on the posterior surface. Then drainage is done using chalazion scoop. I hope all of you have seen a chalazion scoop, guys. If you haven't, then probably I will show you a photograph in the next session, or probably I'll post that as a question in TND or whatever, everybody. Okay, it's just an ice cream scoop, a very miniature form of ice cream scoop. I didn't think that some of you may not have seen it, so I just don't remember to show it to you. Okay, so this is your treatment basically. Now the point is, we know theoretically what is the difference between chalazion and sty. We know how to treat it, but how to be able to diagnose it clinically, whether it is the case of chalazion or sty. Okay, so let's see, everybody, how to clinically differentiate between chalazion and sty. What we understand is that in both chalazion and sty, there will be swelling. Yes or no? Because there is inflammation, there will be swelling in the eyelid. But where is swelling in the eyelid present? Swelling in the eyelid is always away from lid margin. Away from lid margin. Whereas in sty, the swelling in eyelid is always present at the lid margin. I hope you understand why. Where does the Zeiss gland open? Zeiss glands open at the base of lash follicle. So obviously the eyelid margin, the point where your eyelashes are coming out, that will be affected. But in chalazion, it is always away from the lid margin. Somewhere the swelling will be here. It will not be affecting my eyelid margin. So I will bring up a photo on your screen, everybody, and I hope all of you will be able to gladly answer this, whether it is chalazion or sty. Everybody, so this is the photograph, everybody. I hope all of you are able to answer. Option A is chalazion. Option B is sty. I don't think you should have a problem. Anybody here? Let's see if you can answer it quickly, guys. I would not. Oh, yeah, somebody is wrong. One person is already wrong. I would have expected none of you to be wrong. I don't know who is wrong, but majority of you are right. Kashif, Mitvi, Jinal, Mitul, Gautam, Sambit, Meet, Sanket, Mohan, Shubhajit, Vijay, Hasita, Arka. Everybody is right here. I don't know who is wrong. I'm not sure who is wrong, everybody, but somebody is wrong. Only one person is wrong. The rest, all of you are absolutely brilliantly correct. So 13 right, 1 wrong. That's the ratio here in our session right now. Some of you are not answering questions. I don't know why. So please try to answer questions, all questions if possible. Okay. So now, if you will see this carefully, the one person who has got it wrong, you will see that there is this swelling or this kind of nodule which is away from the lid margin. Yes, this is my lid margin. There is a clear space, everybody. Yes, and this is how you say that this is a case of chalazion. I hope you understand. I just got this so that you can see it carefully. So now, if I bring up another image, everybody, if I bring up the second image on screen for all of you. So everybody, this is the second image on the screen. So now what would this be, everybody? I hope you can see that this is the generalized swelling which is involving the whole eyelid, and even the eyelid margin is involved, everybody. I hope you can see that makes it a case of style. Done, everybody. There should be no problem at all in answering any of these two photographs. Very easy to be able to differentiate and diagnose. Done, everybody? Clear, everybody? Between lesion and style, the photographs, everybody. These are two very simple photographs which will be asked, which can be asked. So I hope all of you will be able to answer them, right? Now, coming back, everybody. Please remember, style is also known as, just a special point, style is also known as popularly by, or scientifically or medically by, this name, external hordeolum. So style is also known as external hordeolum. Okay, style is also known as external hordeolum. But what about calasion, everybody? Calasion does not have any other name. Calasion, that's the only name. About calasion, what I would like to tell you is that if recurrent, if calasion is recurrent, you can basically think about sebaceous cell carcinoma. Sebaceous cell carcinoma is suspected, because it is occurring in meibomian gland again and again. Meibomian gland is a modified sebaceous gland, so we may presume it to be a case of, or we may suspect it to be a case of, sebaceous cell carcinoma. Done, everybody? Clear about this? So we are doing pathologies of the eyelid, everybody, or pathologies in the eyelid. We have done two pathologies, everybody. One is calasion and the other is stye. I hope you will be able to remember this two conditions, which are similar but which are actually different also. Okay. Now, coming back to our notes, everybody, we have done this, everybody. Now, there is another condition which is similar to these names. I'm just writing that name, everybody, for all of you. Internal hordeolum. Internal hordeolum. What is internal hordeolum? See, it's hordeolum. It's like stye. Because it is like stye, I will say it is also an infective condition. It is a suppurative inflammation. But of which gland? So it is a suppurative inflammation of meibomian gland. Okay, everybody? Or if you want to call it in another way, it is an infected calasion. Calasion was affecting the meibomian gland, and now that meibomian gland has become infected, so it is causing suppurative inflammation. So basically a mixture of both, gland of calasion and the inflammation of stye. Okay, everybody? Very simple three conditions. I don't think you should get it wrong anytime, anywhere, everybody. This should be as easy as solving any other question, everybody. Yes? Now, there is another important condition of the eyelid, or pathology of the eyelid, that we are studying, which is called as entropion. I hope all of you have heard the name. Again, these are very easy names. So what is entropion, everybody? Entropion is inward turning of eyelid, or I can say eyelid margin. Inward turning of eyelid margin. This is very simple to explain. If you can zoom in into my eye, everybody. Do you see my lower eyelid? Do you see my lower eyelid margin, everybody? Yes. Can you see my lower eyelid margin, everybody? Yes. This is slightly visible. This is neither turned out nor turned in. It is just straight. Okay. But if I show you this photograph, some people find it difficult. Actually, that is why I had to zoom in onto my eyelid. Actually, now try to compare your own eyelid. If you can't see my eyelid, try to compare your own eyelid to this. Can you tell me where is entropion present? Is entropion present in the upper eyelid, or is entropion present in the lower eyelid? Anybody? Option A or option B? Upper eyelid or lower eyelid? In which eyelid do you see entropion? Yes, I hope everybody can see clearly that the margin of the eyelid is not visible. The eyelashes are seeming to be coming from inside, so it is slightly turned inward. So everybody, you've answered it correctly. I'm very happy that you're actually able to see it carefully in the photograph. Okay, a lot of students find it difficult, they miss it on the diagnosis. So the answer is, everybody, lower lid entropion. All of you can see that the lower eyelid is slightly turned inwards. Okay, everybody. Now, entropion, inward turning of eyelid margin. Entropion can be due to congenital causes, or it can be due to mechanical tumors, or everything. But more commonly, or most commonly, we say it is either senile. So it is either senile. Okay, senile means with age, or it is cicatricial. Cicatricial means, I hope you understand what is cicatricial. Yes or no? Due to healing. Yes. So due to healing, if there is some kind of fibrosis or contracture, cicatricial stage. Okay. So senile or cicatricial. Now, infrequently, very, very, very infrequently, they ask you the treatment of entropion. Now, the treatment of entropion is different for senile entropion and cicatricial. I will not be going into the details. I will just be mentioning the names of the surgeons. Okay. Most commonly done surgery in cases of cicatricial is wedge resection. Wedge resection. Please remember this name. Wedge resection. Then the other surgery which is done is called as Burroughs operation. Okay. Now, in senile, you can remember three names by the mnemonic LBW. If you see cricket, you should know LBW, like before cricket, everybody. LBW. Okay. L for Lester Jones operation. Okay. B for Bix procedure, or Bix operation, and then W for Weiss operation, or Weiss operation, however you want to pronounce it, everybody. Okay. So Lester Jones, Bix, and Weiss. Done, everybody. LBW. It is very easy to actually remember it in cicatricial also. There is no L. LBW. It's BW, but there is no L. That's all. Okay. So that is how you remember the names. They used to be asked questions. They are very infrequently asked. Nobody will ask you the steps or go into the details. I'm not going that. That is too far-fetched a question. If it comes, it will be almost an unexpectedly difficult question for you. We can only do so much. We can only remember so much. If you want to read more about it, please feel free to read more about it from your textbooks. But as far as our preparation for any of the exams, whether a third year or a postgraduate, an AIMS or a NEET PG, everything is concerned, that is enough for myself. Okay. Now, you see the photograph of entropion also. That is the more likely question. Now, just like entropion, there is another condition which is called as ectropion. ectropion. Just like entropion, if I reverse it, I will get ectropion. So entropion was inward turning, ectropion is out turning of eyelid margin. Out turning of eyelid margin. Okay, everybody. This is a very easy photo to be able to recognize, and I hope you will be able to see it yourself and answer it very easily. So out turning, this is very easily visible. This is not as difficult as an entropion photograph. I hope I won't have to ask you the question. In the lower lid, you are very easily able to see an ectropion. Yes, everybody. So a lower lid ectropion is very easily visible. Out turning. पूरा ऐसा लटक गया जिसको कहेंगे. Yes or no? The eyelid is turned out and लटक गया है eyelid. Yes. Now, ectropion, everybody. Most commonly, ectropion is found to be senile. Most commonly, it is found to be senile with age. Okay, everybody. So, what are the surgeries done in senile ectropion, everybody? The surgeries done are horizontal lid shortening, you cut the horizontal, you understand? If I horizontally shorten the lid, it will become tighter. Okay, or there is a surgery which is done, which is called as Byron Smith's modified Kunt operation. Okay, Byron Smith's modified Kunt operation. Then everybody, that is what I will restrict myself to in ectropion. I don't think they will go much more in detail on ectropion. Ectropion is senile. Very rarely would you find anybody doing a surgery for ectropion unless it is causing great discomfort to the patient. Ectropion is not as severe as I've shown you in this photograph in all cases. There is minor ectropion in all the cases, and usually occurs by 75 to 80. So I hope you understand what I'm trying to say here. Okay, everybody, done. So that's it about my ectropion. Now I come on to the next pathology of the eyelid, ptosis. Ptosis we have discussed at a lot of places, if you understand, haven't we? Haven't we discussed ptosis, everybody? Ptosis occurs in third cranial nerve palsy. Ptosis occurs in Horner syndrome. Ptosis is drooping of the eyelid. What I'm trying to teach you here, ptosis is drooping of upper eyelid, such that the upper lid covers greater than 2 millimeter of superior cornea. Okay, it covers greater than 2 mm of the superior cornea. What do I mean to say, everybody? If you carefully look at my eye, again I would like to zoom in onto my eye. If you carefully look at my eye, when I'm looking straight, I'm trying to look absolutely straight. Can you see the upper margin of my cornea, everybody? No. See, if I leave my eyelid, everybody, you will see that the upper part of my cornea is slightly covered by my upper eyelid. This is the same fact I had used to explain you the site of laser eyelidotomy from 11 o'clock to 1 o'clock, because the upper part of the eyelid is covered, upper part of the cornea is covered by the eyelid. Yes. So if I have ptosis, it will go down much more. Okay, everybody. I hope I'm clear here that when the upper eyelid covers greater than 2 mm of the superior cornea, then only you will call it ptosis, not otherwise. Okay. Now, ptosis, it can be congenital, it can be acquired. Acquired means due to Horner syndrome, due to third cranial palsy, otherwise. What I'm discussing here is congenital ptosis. How do you find out whether a patient has congenital ptosis? Okay, everybody. Why is it an important topic? Let's try to understand. If a patient is coming to me at 25 years of age and he says that I have recent onset of ptosis, ptosis hoga to problem hoga na vision mein, yes, because it will cover the pupil now. So if somebody is presenting at 25 years of age, I can be almost sure that it is an acquired case. But what if I get a 2.5 or a 3-year-old child? The parents come and say, sir, आपको दिख रहा है eyelid नीचे गिरा हुआ है, that there is ptosis, drooping of upper eyelid. Then I'm in a little doubt. A 2.5 or 3-year-old child. What is the first thing I will do? I will ask the parents whether it is from birth or not. But in a child does not open his eyes properly for the first 6 months or first 1 year. Yes. How is a parent able to actually notice whether there is ptosis unless there is complete ptosis? So if you rely only on the history to find out or diagnose congenital ptosis, it is a little gray area. You're not sure about it. So how to diagnose, let's say, 2-year or 3-year-old child, whether the acquired cause is there, some palsy has occurred after birth, or actually it is a congenitally inherited or congenital ptosis. Okay. So what are the clinical features of congenital ptosis? That is what we are going to do or discuss here. First important question is it is due to, why does it occur? It is due to LPS maldevelopment. Okay. So almost always you will find that congenital ptosis has some problem with levator palpebrae superioris. Now, after this, the diagnostic sign is this: absent upper eyelid crease. Please remember this. This is almost a diagnostic sign. Absent upper eyelid crease. Now, how to explain this to everybody? Again, focus at my eyes. Now, look at my closed eyelid. Even though I have closed my eyelid, can you see this fold, everybody, in my eyelid? Everybody, thumbs up, yes or no? I don't know whether you're able to see or not. See, even though I've closed my right eye, can you see this fold, everybody? Can you see this line or crease in my upper eyelid, everybody? Yes. So such a crease or line is present in everybody's eye. Why? See, because this skin is loose. This skin is loose since birth. So if a child did not have ptosis at birth, he was able to open his eyes at birth. Okay, everybody. That means this skin, everybody, because it was loose, it was being, what do you say? What can I say? It was being folded over each other. Yes. And when you keep on elevating your upper eyelid, this skin keeps on folding, and slowly this fold develops into a faint crease. But if the child had congenital ptosis since birth, that means the child was never able to elevate his eyelids. If the child was never able to elevate the eyelid, this fold of skin never developed. This line, this crease never developed. Okay, everybody. So sure diagnostic sign. I will show you a photograph, everybody. Okay. Again, guys, I don't know whether you're understanding or not. If you are understanding anything, or if you don't understand anything, just make sure to ask me or give me some sign or indication that you do understand this. Everybody, can you tell me which eye has absent upper eyelid crease? Right eye or left eye? Right eye or left eye? Option A, option B. Which eyelid has absent lid crease? So that means basically which eyelid has congenital ptosis? That's my question. Option A, right eye. Option B, left eye. Which eye has congenital ptosis? I hope this should not be a problem at all if you have been able to see the eyelid crease. Okay, so everybody seems to be right. Everybody has answered it very quickly. Mitri, Shubhajit, Mitul, Gautam, Jinal, Sanket, Kashif, Samdip, Vijay, Mohan, Arga, Ajay Kumar. I think these are all the students that are persisting with us. 1, 2, 3, 4. Okay, everybody. So brilliant guys, everybody. You've been able to answer this question correctly. So the answer is left eye. In the right eye, you can see this. In the left eye, you can't see this. Brilliant diagnosis, everybody. So the left eye has absent upper lid or upper eyelid crease. Okay, everybody. Done. Done. Everybody clear? Okay, very good, guys. Now let me go back. So we know this now. Then how else do we diagnose this? We say due to LPS maldevelopment. I'll just write poor LPS function. I'm just writing it so that you understand it. Then we say in down gaze. In down gaze, when the child will actually look down, the ptotic eyelid. This is almost a reverse phenomenon, you can say. The ptotic eyelid remains higher than normal eyelid. Do you understand? That even though the eyelid is already drooped down, but when you actually try to look down, the eyelid does not go further down. The normal eyelid will go completely down, but this eyelid will remain at its level. So if you try to understand it in one line, the eyelid is actually neither going up, neither going down. So when you want it to go up, it is showing ptosis. When you want it to go down, it remains higher than the normal eyelid. Am I clear to everybody here? There should be no confusion. So if you understand it, if you have understood my previous class, this is basically lid lag. Can I call it lid lag? When you are looking down, the eyelid should also go down. But in this case, just like von Grafficein in thyroid associated ophthalmopathy, the ptotic eyelid is not going down. So the eyelid is lagging behind the movement of the eyeball. Okay, everybody? So just like von Grafficein in thyroid, this is presenting. Okay. So two actually opposite signs. There is ptosis, but one going down, it does not go down. The lid lags behind. These are the three diagnostic signs you can say. LPS is not functioning, absent lid is, and lid lag. Now, if you have congenital ptosis, everybody, what would you want to do? You would want to do treatment. So what is the treatment of congenital ptosis? Treatment of congenital ptosis. Treatment of congenital ptosis depends on the degree of ptosis. So if we have, okay, I'll start the other way around. If you have mild ptosis, everybody, if you have mild ptosis and the levator function is actually still good and good LPS function, okay, everybody, and good levator function, then you do a surgery called as Fasanella Servat operation. Please remember Fasanella Servat operation. This is also done for ptosis in Horner's syndrome. I hope you understand why. Because in Horner syndrome, actually LPS is not affected. So the LPS function is always good. Which muscle was affected? Muller's muscle. Okay. Now, secondly, if you have moderate ptosis and what do you say, fair levator function, or a medium kind of function, okay, then you do LPS resection. Okay, resection. Remember, squint. Resection means to cut. Cut means to shorten a muscle, and shortening of a muscle is strengthening procedure. Do you remember? Two words in squint I taught everybody: recession and resection. Recession means weakening. Resection means strengthening. So we are strengthening the LPS muscle. And then if you have severe ptosis and poor LPS function, in this case you do frontalis sling surgery. Frontalis sling surgery. Okay, everybody. So please do remember these three simple points. Again, I think the last question was asked recently in NEET last year, if not this year. Last year, NEET 2019, I think this question was asked that a patient has severe ptosis with poor levator function. Which of the following managements or the surgeries would you like to do? Okay. Now, what do you mean by frontalis sling surgery? Very easy, everybody. Which is this muscle, everybody? Frontalis. So see, to lift my upper eyelid, I can do two motions. Look at my eyes. I am using my, first of all, I will be using my LPS. Everybody see? If I use my LPS and molars, I will be able to elevate my upper eyelid. Can you see, everybody? Okay. Now, everybody, I won't use my LPS and molars muscle. I will use my frontalis muscle and still my upper eyelid will go up a little. See? Do you see, everybody, what I've done? Can you see the wrinkles here, everybody? Okay. Can you see this, everybody? I can't see whether you can see or not. Okay, everybody? Okay, everybody? So even by the use of my frontalis muscle, I can lift up my upper eyelid a little. So what am I doing? I'm taking a silicone thread. I'm punching my skin here. All the skin is connected, everybody. Yes, over my skull bones. I come here, I form a loop in my upper eyelid, then I go up here and again tie it. Okay. So already my frontalis was lifting my upper eyelid. Now I have put a pulley here. So now we teach the patient what? That whenever you want to look up, you have to do this. So with the help of the sling, this will go up even more now. Am I clear to everybody? And that is the basic fundamental behind frontalis sling surgery. Done, everybody? I hope we are clear about it. And this is how you remember congenital ptosis. Now, please remember some special conditions in congenital ptosis, everybody. So this our topic is our topic is congenital ptosis. In congenital ptosis, some special conditions, everybody. One is called as Marcus-Gunn jaw winking syndrome. I would hope that all of you have heard this name various times since your first year, everybody. Marcus-Gunn jaw winking syndrome. I remember that I heard this name first in my anatomy class in first year MBBS. Marcus-Gunn jaw winking syndrome. What is this, everybody? That there is retraction of upper eyelid. retraction of upper lid with what do you say, mastication. Yes, mastication. Done everybody. Now I'll just show you a photograph of this. Though I think this is very ridiculously easy, all of you should have come across such a case or such a understanding. I will hope everybody you can see that in this there is left eye ptosis. Yes, but as soon as the patient is masticating, the eyelid improves, jaw winking. Okay, everybody? Am I clear, everybody? If you will open the jaw, the eyelid will go up. If you close the jaw, the eyelid will come down as if you are winking, jaw winking. Am I clear, everybody? No confusion about it. Done, everybody. Done, everybody. Open jaw, improve ptosis. Done. Okay, brilliant, guys. Now there is another condition which is called as blepharophimosis syndrome. Infrequent, maybe asked as an ectopic question. Blepharophimosis syndrome. Again, I hope you remember the meaning of the word blephar. Blephar means eyelid margin. So as soon as you hear the word blephar, you think about eyelids. Okay, everybody? So in blepharophimosis syndrome, what is seen? First of all, obviously what is seen is congenital ptosis. Then along with that, what is seen is blepharophimosis. So what is blepharophimosis? Blepharophimosis. Blepharophimosis is horizontal shortening of palpebral aperture. Horizontal shortening of palpebral aperture. What is palpebral aperture, guys? The distance between upper eyelid and lower eyelid. But this is which vertical? Which is which palpebral? Vertical palpebral aperture. So this distance from the medial canthus to the lateral canthus. This is what, everybody? Horizontal palpebral aperture. Do you understand this, everybody? If this is my upper eyelid and this is my lower eyelid. So this is my upper lid margin. This is my lower lid margin. This is my cornea, iris, pupil. Okay. So this is my what, everybody? Vertical palpebral aperture. But this is what, everybody? Horizontal palpebral aperture. There is shortening of horizontal palpebral aperture. Very good, Mohan, ready? Okay. Now, so blepharophimosis, and then what else is seen along with this, everybody? What else is seen along with this is telecanthus and epicanthus. Telecanthus and epicanthus. Okay, everybody. So these are the four findings which are found in blepharophimosis syndrome. Okay, done. Now, that's it about my ptosis in short, in sweet, in simple words. I hope you'll be able to solve it. Okay, Samit, you are wondering something. I don't know what you're wondering. If you can post, just ask me the question. Feel free to ask me the question. Now, after we've done the pathologies of the eyelid, I will quickly end up with pathologies of eyelashes. Pathologies of eyelashes. Okay, now, so there are certain pathologies in the eyelashes. I again hope you know the names of these. You know the meaning. They are single straight line questions. Trichiasis. What is trichiasis? What is trichiasis? Inward turning of eyelashes. Inward turning of eyelashes, very simple. Look at the eyelids. The eyelids come out and they go. Okay, can you see my eyelids? I don't know if you can. Yes, you can now. My eyelids are coming out. Can you see now? My eyelids are coming out and they're going out. They're actually turning up. Or if you've seen females, they use curlers to turn it up. Yes or no? Yes. In this case, it will occur opposite. They will turn in. Okay. When they will turn in, they will. What do you do? They will touch my cornea, everybody. So I'll just bring up a photograph on your screen. Everybody, can you see? Can you see these eyelids here on the lateral corner? These are normal eyelids. Yes or no? They are turning out. But see all these eyelids, everybody. All these eyelashes, everybody. What is happening in these eyelashes? They are turning in, they are touching the cornea, rubbing on the cornea, everybody. Yes. So this is called trichiasis. I hope there is no confusion about this. Now let's move back. What is the treatment of trichiasis? So the treatment of trichiasis is basically what? Soch ke dekho. Again, think about the females. Baal nikal jate hai na? Yes, the females get their eyebrows done. What is that called as, everybody? You know, plucking these hairs. That is called as epilation. So basically, you are doing epilation of eyelashes. Whatever eyelashes are turned in, you just pluck them with the forceps. Okay, epilation. Or what can be done is cryotherapy of lash follicles. If it is chronic, if it is troubling the patient lots, so what you do is you do cryotherapy of the eyelash follicles, so they are permanently gone, they will not come back again. Okay, then after trichiasis, the next condition that you should know is called as dystichiasis. Dystichiasis. Now to understand this, just focus on these two words, DI, dystichiasis. Focus on these two words, DI. What are they telling you? Di means something which is double. Okay, so in this case, there is an extra posterior row of eyelashes. So instead of eyelashes being present in one line, there are two lines or two rows of eyelashes. So you have dense eyelashes. Good thing for females. Again, you will have dense eyelashes, but it is at last a disease. Don't think about it. Okay, everybody. Now, again, I will bring up a photograph on your screen. So the next photograph I'm bringing up on your screen will be of dystichiasis. You should be able to appreciate it, even though it is slightly difficultish photograph. If I've got the correct photograph, yes, I've got the correct photograph on screen, everybody. So can you see, everybody? This is the normal row of eyelashes. Okay, at the anterior lid margin, and then you will be able to see a partial second row of eyelashes here. Some eyelashes present here also. Okay, so row number 1 and extra posterior row of eyelashes, row number 2. So thus this is a case of dystichiasis. Okay, so moving on, everybody, let's see other eyelashes problems. So the other eyelash problem which all of us know about is madarosis. If you have read a little bit of dermatology, in dermatology also they mention this. Usually I've seen madarosis. What is madarosis, everybody? Loss of lateral 1/3 of eyelashes. loss of lateral 1/3 of eyelashes. Okay, everybody. So the lateral part of the eyelashes is absent in a lot of patients. Then another important thing is tylosis. So what is tylosis, everybody? Thickening of eyelid margin. Thickening of eyelid margin. Tylosis. Then what else can I tell you here, everybody? Tylosis, madarosis. You already know. Okay, so I'll just tell you one more word here, everybody. Ankyloblepharon. Ankyloblepharon. Everybody, there are two words here again. If you want to remember, just think about English. Blepharon. Blepharon means eyelid margin. Ankylo. Think about ankylosing spondylitis. What occurs in ankylosing spondylitis in the sacroiliac joint? Fusion. Yes or no? So ankylo fusion, blepharon eyelid margin. So fusion of lower lid and upper lid margins. Okay, so fusion of upper eyelid and lower eyelid margin, both of them will be fused together, everybody. So that is called your ankyloblepharon. Okay, everybody. So I think these are certain conditions that you want to study as problems of the eyelashes or the eyelids. I don't think you should have any problem in this, everybody. You should be absolutely simply clear about all these conditions. And that is where I'll complete my chapter on eyelids. I've taken almost 50 minutes, you would see, to teach you eyelids. Why I have explained you a little bit, I've shown you all the photographs is, in NEET PG, usually you will find one question from eyelids or orbit. In this time, orbit, a lot of questions were asked. And they're almost always easy questions if they're asked from eyelids or eyelashes, chalazion, stye, entropion, ectropion, ptosis, and everything. Okay, so please do study this. Whatever 50-minute class we have done on eyelids, and you're sure to get 4 number corrects or 1 question right in your NEET exam. Okay, it's done. So that's it for eyelids, everybody. I hope you enjoyed this. You enjoyed seeing all the photographs and such, everybody. And now I will, everybody, move on to our next topic or next chapter of the day. That will be another chapter which I actually find boring. What I find boring? I find boring those topics where I can't make you understand a lot. I find retina, neuro-ophthalmology, squint, glaucoma, optics, all these I find very interesting because there is a lot of knowledge to make you understand. But in topics like what we have done today, cornea, what we're going to do, conjunctiva or eyelids, there's not much to be able to make you understand. Obviously, if you're studying it for the first time, then obviously you'll find it enjoyable. But apart from that, these topics are what do I say, rectification topics or rote learning topics. If you just learn these, you will be able to get the questions right. Okay, I'll be doing my best in terms of explanations wherever required, everybody. So let's start with conjunctiva. I hope all of you are geared up with your water bottles or whatever bottles you use at night, whatever liquid those bottles may contain of. Even though a lot of bottles these days are very difficult to buy because of the shops are closed due to COVID-19. But you are prepared and you're not feeling sleepy. That is the most important thing. Actually, I am usually a person who sleeps at around like 11:30 or 12. But these days, a lot of students are nocturnal. So I hope you are the nocturnal variety. And this is your starting time, right? So you are like into your zone right now. Okay, guys, brilliant. So let's start with our next chapter, and that is conjunctiva. Now, what is conjunctiva? So what is conjunctiva? Conjunctiva is basically what? It is a transparent mucous membrane. Can I say this? It is a transparent mucous membrane. Okay, which is lining my eyeball on the anterior side. Now, I'll just bring up a photograph to explain you the parts of conjunctiva, how to nomenclate conjunctiva. Okay, so very simple photograph, everybody. See this photograph, everybody. So these are the 3 parts of my conjunctiva. The first part, which is the most easy to understand, is bulbar conjunctiva. So what is bulbar conjunctiva, everybody? All this, where my pointer is now moving, everybody. So this conjunctiva, which is covering the sclera. If you remember the first class, I always said the white part is sclera. But when I touch the white part, I've done this. When I touch the white part, do I touch my sclera? No, I'm actually touching now my conjunctiva, because over the sclera, the transparent mucous membrane, that is conjunctiva, is present. So that is your bulbar conjunctiva. Okay. Now, the second conjunctiva, which you want to understand, is this. First of all, palpebral. So I am again and again showing you this. Yes, we discussed in the anatomy of the eyelid that the posterior surface of the eyelid is covered with conjunctiva. Okay, the posterior surface of eyelid which is covered with conjunctiva is your palpebral. Then in between the two, in between the bulbar and the palpebral, there is kind of a depression there, and that is called the fornix. So that conjunctiva is called the fornix. So basically, it is covering the sclera, then it is coming back and lining the eyelids. Do you understand this, everybody? Am I clear, everybody? I hope I am clear, everybody here. Yes. Then this corner, everybody, I'll just mark this. This corner. Okay, I'll mark this. Then I'm rubbing it now. This corner, everybody. In this corner, if you try to feel it, there is a small nodule kind of lesion. Can you feel it? Try to feel it in your eye, everybody. At this corner, don't push on the lacrimal side. Don't push here. In this corner, there is a nodule kind of a thing. This is nodule kind of a thing is called as caruncle. This is called as caruncle. Okay, everybody. This is called as caruncle. These are just rudimentary structures, you can say. Then can you see this fold, everybody? Can you see this fold? Again, I'm marking it first, then I'll be rubbing it. Okay. So when it goes medially, the conjunctiva forms a small fold. This small fold here is called as plica semilunaris. Plica semilunaris. This is what is called as the nictitating membrane in animals. This is rudimentary in us. I hope you can see this line, everybody. A line of fold here, everybody. Okay, everybody. Just telling you. I don't think question will be asked on this, but just telling you because I have a photograph here and I can show it to you. Okay, everybody. Done. No confusion. Everybody clear about this? Parts of our conjunctiva. Now, what do we want to know? Histology or the layers of conjunctiva? Layers of conjunctiva. So, everybody, after the parts, number 1, the outermost layer. The outermost layer obviously will be called as epithelium. Just like the cornea, everybody. Yes, corneal outer layer was also epithelium, conjunctiva outer layer is also epithelium. And just like the corneal epithelium, this is also non-keratinizing or non-keratinized stratified squamous. non-keratinized stratified squamous. Okay, I don't think anybody will ask you this, but just telling you. Important thing is they will ask you that this conjunctival epithelium contains a special type of cell which is called as goblet cells. Conjunctival epithelium contains goblet cells. So the question they can also ask you is where are goblet cells present in the eye? Am I clear to everybody? They can ask you the reverse question. Where are goblet cells present? So the goblet cells are present in the conjunctival epithelium. Why are they important cells to us? Because goblet cells secrete mucin. Goblet cells secrete mucin. I hope you understand mucin. What is the function of mucin on the surface of my eye? Mucin forms which layer of the tear film, everybody? Mucin forms which layer of the tear film, everybody? Okay, I'll give you options. A, innermost layer. B, middle layer. If you know the layers, I don't know if you know. Or C, outermost layer. There are 3 layers of the tear film. Let's see if you know the answer. Which layer of the tear film is formed by goblet cells? Innermost, middle, or outermost? 71% of you. Okay, only 25% of you are correct. Rest of all of you are wrong. So only Subhajit, Mitvi, and Hasita and Vijay. Now 4 people are correct. 6 people are wrong. Subhajit, Mitvi, Hasita, Vijay. 4 people are correct. Okay, I'm waiting for other answers, if any. Okay, that is all the answers that I've got. So please remember that mucin forms the, as 4 people have answered, you would have seen the answer by now, innermost layer of tear film. It forms innermost layer of tear film. Okay, everybody? Forms the innermost layer of tear film. Now, tear film has 3 layers, everybody. I'll just write here. I'll just draw a box here and write it quickly for you. So tear film has 3 layers. A, innermost. Innermost, as I just told you, is formed by mucin, which is secreted by goblet cells. B, middle layer. Middle layer is formed by aqueous or aqua or water, I will say. I will simply say water, everybody. Water is secreted by lacrimal gland. Lacrimal gland, accessory lacrimal glands. And C is the outermost layer. Outermost layer is formed by lipids, and they are secreted by meibomian gland. Okay, everybody. Sebum, sebaceous lipids. Okay, everybody. So if you understand the functions, everybody. Middle layer, first of all, what we think about tears, asu, pani. Yes or no? That is what we think about the tear film. That the middle layer, which is water, is the most important. Yes, water is the most important. It makes our surface remain wet. But if water will be exposed to the environment or air, it will evaporate. So to protect the water from evaporation, outside the water, the outermost film, which will be in contact with the environment, is formed by lipids. You understand? Lipid is oil. When you mix oil and water, oil comes at the top. Yes or no? Basic physics here. And these lipids are secreted by meibomian gland to stop the evaporation. Then everybody, how will this water and lipids stick to the eye? पानी तो गिर जाएगा ना, आंसू छलक जाएंगे. Yes, पानी गिर जाएगा. So how to make this tear film stuck to the eye? So you need some kind of mucus to stick it to the eye. That is why the innermost layer, everybody, is formed by mucin, and that mucin is secreted by goblet cells. So each layer beautifully formed has a function: mucin sticking, water wettability, and lipid to stop the evaporation. I hope you understand the simple function of tear film and its formation. Okay. Now let's get back to our layers of conjunctiva. The outermost layer is epithelium, and you know the importance of goblet cells. Who is wondering, and what is that person wondering? I don't know. What are you wondering? What are you wondering? Are you wondering about tear film? Mitul? What are you wondering? I don't know. I just try to explain. Innermost layer means which is in touch of the cornea, चिपकाएगी mucin से, फिर पानी आएगा गीला करने के लिए, and then lipid will be the outermost layer to stop the evaporation. Okay. Now, if you're wondering anything else, if you can't ask or type here, please feel free to ask me any doubt on my Facebook after the session ends. Okay. Number 2, everybody. So the second layer, everybody, is called as stroma. The second layer is called as stroma. Now, stroma is divided into 2 layers, or stroma is divided into 2 parts here. The first part is called as the adenoid layer. Adenoid layer. Okay, adenoid layer, obviously adenoid means lymphoid tissue. I hope you understand. This adenoid layer does not develop till 3 months of age. Okay, it does not develop till 3 months of age, or I can say it develops after 3 months of age. Okay, and that is the only important point that you want to remember here. And then the second layer is called as the fibrous layer. The second layer is called as the fibrous layer. This fibrous layer contains the accessory glands, accessory lacrimal glands. Okay, this contains the accessory lacrimal glands. Okay, that's it. Okay, so if you can consider these 2 parts of the stroma, it's okay, or you can consider them 3 layers, and these are the 3 layers of conjunctiva. Number 1, epithelium. Number 2, adenoid layer, which is a part of stroma, and number 3, fibrous layer, which is again a part of the stroma. So very simple anatomy. The layers, everybody. The only thing I wanted to emphasize on was the position of the goblet cells and their importance in the formation of tear films. Okay, everybody. Now, apart from this, in the anatomy or in the basics of the conjunctiva, the very important thing which you want to learn is that conjunctiva is the only structure in eye having lymphatic drainage. Please remember this. Very simple question they will ask you. Lymphatic drainage from the eye occurs from which part? Okay. Lymphatic drainage of the eye occurs from. The only answer is conjunctiva. Please remember, lymphatic drainage in the eye occurs only from conjunctiva. Only from conjunctiva. Now, if they're asking you that lymphatic drainage is occurring from conjunctiva, so what the next question they will ask you? Where does the lymph drain? Lymph drains into which of the following lymph nodes? So lymphatic drainage can be divided into 2 parts: medially Where does it drain into which lymph nodes? And laterally. So there is a very simple fun way to remember this, guys. Okay, the simple way is lymph flows like your tears. जहां जहां आपके आंसू बहते हैं वहां वहां lymph जाता है. Okay, everybody, lymph flows like your tears. So let's say because of the lockdown, you are homesick. If you are living in your hostel, I don't know, or whatever, and or because of any reason you are crying because of your inability to solve MCQs, you are exasperated, you are crying. Let's say you are crying right now, sitting in front of the screens. I can't see you, but if I would have been able to see you, your what tears would have come out from this point. Yes or no? यहाँ से आंसू आते, ऐसा जाता गाल के ऊपर से, and then it would have gone here, and then it would have done tap tap tap. Yes. So this is the way your tears would have flown from which part of the eye? Everybody, medial part. So this is where the lymph goes from the medial part. From medial part, lymph flows here. What is this bone? Everybody, mandible. Below the mandible, which glands do we have? Everybody, submandibular lymph nodes. Okay, done. Or let's say you don't feel like crying right now, but after the day ends, just before going to sleep, thinking about a lot of things in life, you feel like crying. So you're lying down in your bed, and now you're crying. Okay, so सिसकियां भरते हैं जिसको कहते हैं. Okay, so you're lying down. When you're lying down, where do your tears come from? Here. Then they go here, 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 here. Then they go into your ear, everybody. Yes. So auricle. In front of the auricle, what do we have, everybody? Preauricular lymph nodes. Preauricular lymph nodes. Okay. So just a fun way I can say, whenever you want to remember the lymphatic drainage of the eye, just think of crying. That whenever you have cried, where have your tears gone? Medially, they would have gone here, submandibular, and laterally, when you are lying down, they would have gone here, preauricular lymph nodes. Am I clear, everybody? No confusion here. Done. And this is your lymphatic drainage. Simple 3 questions, but they are asked. Please do remember that. Please do try to remember them at least. Okay, guys, brilliant. Done. Lymphatic drainage done. Okay. Now, after lymphatic drainage, what do I want to do? I want to do the topic, which is probably the only disease I can say pathology apart from IBGM maybe. So the thing that we are doing now is conjunctivitis. Okay, so what is conjunctivitis? If I need to explain this to you, then I will explain it to you. Okay, so itis means inflammation. Conjunctiva, inflammation of conjunctiva. This is in short what we have learned to call as eye flu in our day-to-day layman language. क्या हो गया? आई फ्लू हो गया, लाल आंख हो गई. Yes or no? आई फ्लू में क्या क्या होता है? सोचो. The eye becomes red, there is discharge, there is sticking, there is pain, and then your parents, if you were a child, they would have told you don't rub your eyes, wear a black spectacle so that you don't transmit it. It is contagious. Blah blah. Okay. So basically, what is eye flu is conjunctivitis. Now, what will be the symptoms of conjunctivitis? I don't think I should be able to tell you anything new that you already don't know, but just for the sake of mentioning it to you here, everybody. So what will be the symptoms, everybody? So the first important symptom will be redness. My air conditioner doesn't seem to work, guys. Let me see. Okay, so the first symptom is redness. After redness, what will you get, everybody? You will get chipkan, chipka hua, stick, or I can say stickiness. Then you will get foreign body sensation. Okay, you will obviously have some watering, or I can say lacrimation. And what else can you have, everybody? You can have a little bit of itching if the cause is allergic. Obviously, if you have allergic conjunctivitis, then you can also have itching. So basically, okay. But please remember, there will be no pain and there will be no loss of vision. If there is pain or loss of vision, then that means there is corneal involvement. That means it is not only conjunctivitis. That would mean it is keratitis also. So let's say a patient of herpes simplex virus is coming, and that herpes simplex virus patient is complaining of loss of vision, but you see conjunctivitis. But because of the loss of vision, you should be sure that the patient also has keratitis. So you should stain the cornea to find out a dendritic ulcer or a punctate keratitis or a geographic ulcer or something like that. Am I clear, everybody? So please be aware that pain and loss of vision do not indicate conjunctival problems. Loss of vision, conjunctiva has nothing to do with vision. Where does the light go from? Cornea. The light does not go from conjunctiva or from sclera. Pain, it will not have any pain here, everybody. Yes, pain will be there when there is chode. This is just inflammation. Okay. Done. What are the signs, guys? So in signs, number one, as I again and again said, what is redness? Redness is a symptom. The same, if we convert into a sign, is called as hyperemia, or I can call it congestion of blood vessels. Yes, very simple. Then what will be the second important sign, everybody? Stickiness, everybody. If stickiness is occurring, or some watering is occurring, I can call it what, everybody? Discharge. Third, everybody, this can lead to subconjunctival hemorrhage. Obviously, due to inflammation, the vessels may hemorrhage. So the fluid will collect, the blood will collect, and I can call it subconjunctival hemorrhage. Please remember, subconjunctival hemorrhage can also occur in blunt trauma, as I would have told you. And it often is found in patients who have hypertension. Okay, subconjunctival hemorrhage is self-limiting as a sign itself. You can't do anything about it. It's a small spot of blood. That's all. Okay, everybody, just ignore it. It will resolve in a few days. The blood will break down, hemosiderin, blah blah blah, and it will resolve on its own. Okay, but it is a sign of hypertension in old age. Please do remember this. Now, the next sign, everybody, that you should know is called as chemosis. So chemosis, I had mentioned today morning when I was teaching you cavernous sinus thrombosis, that chemosis is present in cavernous sinus thrombosis, marked chemosis. So what was chemosis? If any one of you remembers, any one of you has revised, swelling of bulbar conjunctiva. There I had not mentioned the word bulbar because probably you may not have known that word. But please remember, chemosis does not mean swelling of the whole conjunctiva. It only means bulbar. Bulbar, I hope you understand now. Bulbar conjunctiva, the part which is covering the sclera. I have a decent photograph which can probably explain you this. So everybody, if you can see this, don't see this photograph, ignore this photograph, see this photograph, everybody. Okay, can you see in the bulbar conjunctiva there is collection of fluid? ऐसा लग रहा है थैली के अंदर पानी भर दिया हो. Yes or no? It's almost like a transparent polythene. Polythene के अंदर पानी भर दोगे, so it will, just loop down a little. Okay, so this is your chemosis. Then everybody, no confusion about this. Then the last important sign is inflammatory reaction of conjunctiva. Inflammatory reaction of conjunctiva. If inflammation is occurring in conjunctivitis, conjunctiva will show some inflammatory response, inflammatory reaction. These inflammatory reactions can be of two types. The first is called as papilla. Very important, everybody. This is the basis of your conjunctivitis. If you understand this, there is actually nothing much more to understand than everything else. You just need to remember. So there are two inflammatory reactions. One is called a papilla and the other is called as follicle. What is a follicle? Follicle is basically a lymphoid aggregate. Follicle is a lymphoid aggregate. Lymphoid aggregate will appear what color, everybody? So it will be whitish lesions. Okay. But what is a papilla? Papilla is hyperplasia of vascular system. So what will this present as? This will present as raised red color lesions or nodules. Nodules is actually the wrong word. Raised red color lesions. So the vessels are getting inflamed, hyperplastic. So this is the basic difference. That this is a reaction by the vascular system, but this is a reaction by the lymphoid system. That is why the appearance is either red in color or white in color. That is what is actually all that is needed to know in conjunctivitis, whether it is a papillary conjunctivitis or a follicular conjunctivitis. So I'll just show you both the photographs so that you're able to understand it once and you'll never have a problem understanding this in your life again. Okay. So if I show you this photograph, I hope it is very, very, very simply visible. You see small, small raised lesions, globules. But these are which colored lesions, everybody? Red colored lesions. So these are what, everybody? Papilla. All these are papilla. Can you see, everybody? Can you appreciate them? Can you understand them, everybody? Yes? Now, if I bring up the next photograph on your screen, you should be able to understand the difference. Okay? Everybody, what are these? Can you see these whitish lesions? I'm just marking some of them for you. The others you will be able to see this. There are so many follicles here. Okay, so slightly small raised but white lesions, everybody. Yes or no? So these are your lymphoid aggregates. That means these are your follicles. I hope I'm being very, very, very simply clear about these two. If you understand this difference, then in your clinical practice also, if you're an intern or a JR, you should be able to solve all these cases yourself, whether it is a case of papilla or it is a case of follicle. Follicle, papilla, red colored, raised flat top lesions. This is follicle. Papilla, follicle, papilla, follicle. Everybody? Now, if you are clear about this, then my probably job is done here. Now I can basically tell you how to approach the cases or questions, cases in terms of your clinics and questions in terms of your examination. So I'll just give you a simple table. If you understand this table, you understand a lot about conjunctivitis. So as I told you that any conjunctivitis can either present with papillae or it can present with follicle. Similarly, there will also be discharge. The discharge usually can either be watery, pani jaisa, or it can be mucopurulent, mucus and pus. Okay. Now, based on the combination papilla or follicle, watery or mucopurulent, you can have your group of conjunctivitis. If a patient has papilla along with watery discharge, then you are sure that the patient has allergic conjunctivitis. Okay, everybody. I'm just writing which type of conjunctivitis. If a patient has papilla with mucopurulent discharge, then I have bacterial conjunctivitis. You understand? Very, very, very important thing here. But if you have follicles along with watery discharge, then you have viral conjunctivitis. But if you have follicles along with mucopurulent discharge, you have chlamydial conjunctivitis. As simple as that. So read a question, see which type of discharge the patient is complaining of. Agar mucopurulent discharge hoga, if there is mucopurulent discharge, so there will be stickiness. If there is watery discharge, the patient will say, I just, there is some watering, lacrimation, but the eyes don't stick. Then you will examine it, papilla or follicles, and then you will be able to group it. Okay, everybody? If you are able to do this, then you are able to group your type of conjunctivitis. And through this, we also understand the types of conjunctivitis. There are 4 types of conjunctivitis: allergic conjunctivitis, bacterial conjunctivitis, viral conjunctivitis, and chlamydial conjunctivitis. Am I clear to everybody? If we are clear about this, half of our job is done. So in all cases of allergic conjunctivitis, there will be papilla along with watery discharge. In all cases of bacterial conjunctivitis, there will be papilla with mucopurulent discharge, and so on. Okay, I'm not going to keep on mentioning it again and again. I'm not going to write it again and again. Okay, so there are 4 groups of conjunctivitis that you want to study: bacterial, allergic, viral, and chlamydial. Let's start first of all with bacterial conjunctivitis. Bacterial conjunctivitis. Okay, bacterial conjunctivitis. Now, you people are saying a hi to me. Okay, hi to you also. Whoever is saying a hi to me. I don't know who is just given me a hi. Okay, so bacterial conjunctivitis. Okay, Yash, hi Yash, hi Yash. Okay, bacterial conjunctivitis. Bacterial conjunctivitis means again bacteria. So you already know there will be papilla plus there will be mucopurulent discharge. Nothing new to explain. Now, bacterial conjunctivitis can be of various types. I will just be very simple and quick with this. The most common type is called as acute mucopurulent conjunctivitis. Acute mucopurulent conjunctivitis. In acute mucopurulent conjunctivitis, you already know there will be mucopurulent discharge, there will be papilla, there will be all the other signs and symptoms. What you need to know is what is the most common cause. So the most common cause is Staphylococcus aureus. Staphylococcus aureus. That's all. Simple. Okay. And the second is called as acute purulent conjunctivitis. There is no mucus, only pus. Also called as hyperacute conjunctivitis. also called as blinoria. Please remember the name, also called as blinoria. Okay. Now this is an important condition. Important because it is hyperacute. Important because it is rare, but it is a severe condition. So what is the cause first of all? So it is caused by Neisseria. It is caused by Neisseria gonorrhoeae. Okay. So this is the most common cause, Neisseria gonorrhoeae. Okay. Then I hope you understand gonorrhea is a genital disease. Yes. So it has oculogenital transmission. Oculogenital transmission by hand, obviously. Okay. So you touch your genitals, then you touch your eye. Oculogenital transmission by hands. Okay. Then what is the important point? So there is, I will say, clinical features. Apart from the normal clinical features we have, there is intense pain plus severe swelling of eyelids. Remember, whatever we have discussed about conjunctivitis till now, this has nothing to do with swelling of the eyelids, but in this case, there is severe swelling of the eyelids. Plus, everybody also remember there is pre-auricular lymphadenopathy. Pre-auricular lymphadenopathy. Okay. Pre-auricular lymph nodes, lateral lymph is discharge, pre-auricular lymphadenopathy. Okay. So apart from all your papilla, your purulent discharge, your subconjunctival hemorrhage, and everything else that we have discussed, redness, foreign body sensation, there will be very severe pain, swelling of eyelids, and pre-auricular lymphadenopathy. So these are the three diagnostic clinical features of acute, purulent, or hyperacute conjunctivitis or blinoria, what we call it. If you know what is the treatment of Neisseria, I don't think I should be telling you anything. So what is the treatment of this condition? Everybody, I'll just quickly mention it. I hope you know which drug is used. Everybody, anybody who can type in. New students who have joined, if you can type in Smith, Jyoti, or Yash, or any of the old students, Mohan, Ajay, or anybody else, everybody, what is the treatment? Which drug is given? Nobody? No? So IM, intramuscular ceftriaxone, 1 gram single dose. Okay. Then this is to be followed by oral erythromycin for 2 weeks. Okay. So this blinoria almost always presents along with urethritis. Again, please remember it is gonorrhoeae, genitals, oculogenital. So it presents along with urethritis. Done, everybody? So that's the second condition in bacterial conjunctivitis, which is an important condition. So it presents with urethritis along with conjunctivitis. You know, intense pain, blah blah, whatever I have told you. Okay, so first condition was acute purulent. The second condition is acute hyperacute or blinoria. Now, moving on, everybody. Okay, so I just missed the photographs there. Okay, then the next condition is, sorry, then the next condition is acute membranous conjunctivitis. Acute membranous conjunctivitis. Okay, acute membranous conjunctivitis. Membrane is forming. In this, again, they ask you the question most common cause. So the most common cause is actually different in children and in adults. In children, the most common cause of membranous conjunctivitis is Corynebacterium diphtheriae. I hope now you know that with our immunization and all the things, diphtheria, we give DPT vaccine. So it is. So the incidence is very low, but the most common cause in adults, everybody, is Streptococcus hemolyticus. Smith Patel, the answer to your query is in the first week of June. Okay. Most common cause in children, most common cause in adults. Done, everybody? No confusion about this? Now, in acute membranous conjunctivitis, please remember that on membrane removal, it bleeds. On membrane removal, it bleeds. Okay, everybody? Bleeding hoga because the membrane has become fused with the underlying structures. Necrosis hua. Necrosis ke baad it has become fused. So when you try to remove the membrane from the inside of the conjunctiva, then the blood vessels will be ruptured and there will be a lot of bleeding. Everybody, am I clear, everybody? Now, the next condition here is acute pseudomembranous conjunctivitis. Now, everybody, the basic difference is this word pseudo. What is the difference between a membrane and a pseudomembrane? The only difference is it does not bleed on removal. Okay, it is a pseudo membrane. It is not a true membrane. So it is not becoming adherent with the underlying tissue. There is no necrosis along with this membrane. So when you want to remove it, you can just remove it like a tape. I will bring up a photograph on your screen, everybody, and I hope you will all be clear about this fact that what is a pseudo membrane, everybody. So this is a case in which pseudo membrane peeling is being done. Everybody, do you see this yellowish colored membrane? I just take a forceps and I try to remove it. Everybody, yes. So there is pseudo membrane peeling because there is no associated bleeding. Am I clear to everybody about it? Am I clear to everybody about it? Okay. If it would have been a membrane, when I would have tried to remove it, there would have been copious bleeding. Done, everybody. And now the next or last condition, everybody, in bacterial conjunctivitis is an important condition again, which is called as angular conjunctivitis. Important condition because its cause is rare bacteria. What is the most common cause, everybody? So the most common cause is Moraxella. The most common cause is Moraxella, Moraxella lacunata, Moraxella Axenfeld. Am I clear, everybody? Then what are the important clinical features here, everybody? The important clinical feature, the most important clinical feature here is excoriation of skin at canthi. Excoriation of skin at canthi. What are canthi, everybody? Canthi is this corner of the eye. This corner is called the medial canthi. This corner is called the lateral canthi. So the usual complaint of the patient will be that the patient will say, sir, यहाँ पर बहुत सारा rubbing करना पड़ता है, यहाँ पर थोड़ा सा itching है, pain है, and when you will examine it, you will see excoriation. Excoriation means due to some kind of सूख गया skin. Yeah, if you want to understand in very simple language, सूख जाता है and then there is fissuring of the skin. Okay, so at this corner there will be fissuring, there will be drying, there will be scaling, जिसको कहते हैं पपड़ी बन जाना. Okay, all those things will be present. Excoriation of skin at canthite. Okay, then there can also be associated blepharitis. There can be associated blepharitis. Then, because it is a specific bacteria, Moraxella, the treatment is specific. The treatment is tetracycline eye ointment. Tetracycline eye ointment, 1%, and along with that, zinc plus boric acid eye drops. Zinc plus boric acid eye drops. So these are the two treatment options that we have: tetracycline eye ointment and zinc plus boric acid eye drops. Okay, everybody done. Both of these need to be instituted in a case of angular conjunctivitis. Please do remember these simple points. So this is our bacterial conjunctivitis done, everybody. Let's revise. Papilla of mucopollen discharge. Important condition: hyperacute or denuded neisseria. In neisseria, there will be associated oculogenital urethritis. There will be intense pain, but there will be swelling of the eyelids, and there will be preauricular lymphadenopathy. Then difference between membrane and pseudomembrane. Membrane will bleed on removal. Pseudomembrane will not bleed on removal. Angular conjunctivitis, Moraxella and canthite. Please remember this word: Moraxella and canthite. Done, everybody. Angles. You understand angles? Angles. The corners of the angles. Done. So that's all about my first type of conjunctivitis, that is what do you call it? Bacterial conjunctivitis. Now we move on to our second type of conjunctivitis. My second type of conjunctivitis that we're discussing is viral conjunctivitis. Now, I hope you remember that viral conjunctivitis was presenting with papilla or follicles, everybody. Papilla or follicles, it was presenting with follicles, and it had which kind of discharge, everybody? Watery discharge. Okay. So again, I will say focus on the main table that I've shown you. I'll just quickly go back to it for all of you, everybody. So this is the main table, everybody. I hope all of you remember this. That viral, if we are discussing, we're talking about follicle with watery discharge. Okay, everybody. Done. Now, let's come back to our main screen. What we are doing actually, viral conjunctivitis. Okay, follicles plus watery discharge. Now, viral conjunctivitis can be due to a lot of types or causes. The most important question that is asked and very commonly asked is acute hemorrhagic conjunctivitis. Acute hemorrhagic conjunctivitis. Now, questions are asked on this, and always the same question is asked: what are the causes? From the name, it is very clear, everybody. Acute hemorrhagic, acuticity, and there is a lot of hemorrhage. Yes, this is also called as Apollo conjunctivitis. This is also called as Apollo conjunctivitis. So what are the causes, everybody? So the first important cause is picorna virus. Picorna virus. Okay, everybody. Now, if you ask me which types of picorna virus, then the other two options are actually types of picorna virus. So the cause is, everybody, enterovirus, serovar or type 70. Then Coxsackie virus, A24. Please remember A24. They always give us an option B24. Okay, so please remember Coxsackie A24. Then the next virus is adenovirus. Which type of adenovirus? Type 11. Okay, it is important to remember the types also, because earlier they used to ask, or this is there are various varied questions. All of the following cause acute hemorrhagic conjunctivitis except. But in 2018, I think they asked the question, which serovar of enterovirus causes acute hemorrhagic conjunctivitis? So they also wanted you to remember this type 70. So basically, guys, just 4 names you want to remember. Okay. Now somebody asks you what is the most common cause. Adenovirus is least common. So if I ask you now in picorna, entero, and Coxsackie, what is the most common? So obviously picorna will be most common, yes or no? Because entero plus Coxsackie is equal to picorna, yes. So if somebody asks you what is the most common cause, obviously the answer has to be by common sense picorna virus. Okay, done. I don't think you should have any at all problem in this, and I hope you will be able to solve this question. Now, apart from this, everybody, if I ask you what are the manifestations of adenovirus or adenoviral conjunctivitis, so adenovirus can cause two basic things. One is called as EKC. EKC is epidemic keratoconjunctivitis. This is caused by type 8, 1937. Then the second is called pharyngoconjunctival fever, PCF. Pharyngoconjunctival fever. So basically, you have pharyngitis, you have conjunctivitis, and you have fever. This is caused by type 347. 3 plus 4 is equal to 7. 347. Okay, everybody, very simple to remember EKC and PCF. There should be no confusion about this. Done. In EKC, they ask you which type of hypersensitivity. So EKC is a type 4 hypersensitivity. EKC, epidemic keratoconjunctivitis, is a type 4 hypersensitivity response of the conjunctiva to the virus. Done, everybody? And that's all about viral conjunctivitis from my side. Nothing difficult, short and sweet, and simple questions are asked. Done. Now I move on to our next, that is chlamydial conjunctivitis. Now, everybody, chlamydia, I hope you know. Yes or no? Chlamydia trachomatis. Yes or no? Chlamydia trachomatis. So when we talk about chlamydial conjunctivitis, first of all, we know that chlamydia will cause what, everybody? Follicles. But the discharge will be mucopurulent discharge. Okay, that is the first thing that we want to remember. Now, what are we talking about? We are talking about chlamydia trachomatis. If you remember your microbiology, guys, otherwise I'm just quickly revising it with you. Chlamydia trachomatis can be basically of a lot of groups or serovars, D to K, and then we have A, B, C. Okay, so A, B, C trachomatis or D to K serovars. A, B, C causes the most important condition which is also covered as part of Vision 2020 in India, if you remember. Trachoma and D2K cause two conditions. One is called as adult inclusion conjunctivitis, and the other in children, which I will discuss, important condition, ophthalmia neonatorum. Ophthalmia neonatorum. Okay, everybody? Done. I hope there is no confusion about this. In this adult inclusion conjunctivitis is nothing to be discussed about. I will not be discussing it. It has inclusion bodies which are called as HP bodies. That is why it is called as adult inclusion conjunctivitis. If you don't know, please remember inclusion bodies, HP bodies. I hope you know your basic microbiology, guys. Yes or no? Helper, Stadler, Proba, Zecchi bodies, intracytoplasmic inclusion bodies are seen. Okay, that's it. I'll be discussing the two main conditions with you. The first is trachoma, and then the second will be ophthalmia neonatorum. So let's start with the most important condition, everybody, that I will be probably teaching you in conjunctiva: trachoma. Trachoma in earlier days was also known as Egyptian ophthalmia. It was also known as Egyptian ophthalmia. A lot of times you do get questions based on the older names of some conditions also. Okay, so that's why I'm just telling it to you. Trachoma, also known as Egyptian ophthalmia. Done, everybody? Now, please remember, the trachoma is a chlamydial conjunctivitis, so it is follicular, it has mucopurulent discharge. Now, we already know that it is being caused by which serovirus, everybody? A, B, and C. Now, it is transmitted by F. What is F, everybody? Finger, fly, and fomite. So if there's a case of trachoma, you rub your eye and then you touch somebody else's eye, finger, fly. A fly will come and sit on your eye. Or fomite. Fomite means any object which can be used for spread, everybody. Let's say I take a handkerchief and I rub my eye, and then that handkerchief is used by use. Okay. So finger, fly, and fomite. Done, everybody? Now, important clinical features. Please remember that the clinical features are A. It is primarily a follicular conjunctivitis. So sago grain follicles. The follicles are very, very small. Sago grain, I don't know if you've seen that grain. Sabudana, like sabudana bhi nahi, usse bhi chota hota actually. I don't know the Hindi name of it, probably sago grain. It's a very small grain, and the follicles are that small in size. So that is why they are simply called as sago grain follicles. Okay, everybody? Now, secondly, we say even papilla are seen. Papilla are also seen. Even though I'm saying it is primarily a follicular conjunctivitis, but papilla are also seen. So this is mixed papillary plus follicular. Just remember this, everybody, that if in the options it is written which type of conjunctivitis it is, if it is only follicular, you answer it. But if the option is mixed papillary and follicular, you answer that. That is the better answer. Okay, everybody? Done? Now, other clinical features, everybody. The other important clinical feature is Arlt's line. Arlt's line. So what is Arlt's line, everybody? It is the line of cicatrization or healing. Okay, everybody? So this is the line of, or I can say scar slash line of cicatrization. Okay, slash, I'll just show you a photograph, just let's write it. Then the next sign is something called as Herbert pits. Please remember these names. These are very, very important signs, everybody. Okay, so these are depressions seen at limbus after or due to cicatrization of limbal follicles. So the follicles which were present at the limbus bulbar conjunctiva, yes or no, when they cicatrized, when they healed, so they left some depressions at the limbus, and we are calling those depressions as Herbert pits. Pit mane gadda. You understand this? And then the last important sign is pannus. What is pannus, everybody? Pannus, anybody? Pannus. So what is pannus, everybody? Pannus is superficial vascularization of the cornea. Superior vascularization of cornea. Cornea is avascular. I hope you will remember this, that cornea is avascular, but in this case you will find that there is infiltration happening in the cornea, and along with that there is vascularization which is happening in the cornea. Okay, so please remember sago grain follicles. Then please remember the important features: Arlt's line, Herbert pits, and pannus. Now I'm bringing up photographs, everybody. Let's try to find out. Please remember Arlt's line is a line of cicatrization, so you will see some kind of a scar or some kind of a healing. Okay, everybody. So this is the photograph of Arlt's line, everybody. This is my upper lid. I hope you understand that the upper lid has been everted. Yes, upper lid has been everted like this. Okay, everybody. If I evert my upper lid, I don't know if you can see it. Can you see it now, everybody? Yes. So I have everted my upper lid like this. I don't know if you can see it. So this is the line of healing or cicatrization. Where is it present, everybody? It is present between upper 1/3 and lower 2/3. Am I clear, everybody? So evert kiya to eyelid ulta ho gaya. So this is the upper part, upper 1/3. This is the lower part. Yes or no? Can you see the eyelashes coming out from here? So this is actually the upper part which is now visible down, and the lower part which is visible up. Okay, everybody? Arlt's line. No confusion? Now, next photograph, everybody. So the next photograph on screen is this. Everybody, where do we see the lesion? Everybody, where do we see the lesion? This is our sclera. This is our cornea. Do we see some kind of pits? Do we see some kind of pits here, everybody? Yes, very good, Mohan Sai. Yes. Do we see some kind of pits at the limbus? 1, 2, 3, 4, 5, 6. Yes. So the diagnostic here is that the lesion is at the limbus. That is what you want to first of all focus on. I always say to be able to find a sign, you need to know the site of the sign. So you need to look at the limbus to be able to find out the limbus. Okay, everybody? Okay, very good, guys. Very good. So this is Harvard pits. And lastly, if I have a photograph of Panis, I'll just make sure that I show you that photograph also. Okay, so you can see the photograph of Panis also on screen, everybody. There should be no confusion in this photograph. You will be able to see that the superior part of the cornea has become vascularized. So this is our Panis. No problem. I hope everybody done. No confusion about this. Done, everybody? Okay, brilliant, guys. So these are our signs and all the photographs that I've shown you of the trachoma signs. Okay, now please remember that there is a complication of trachoma. The complication of trachoma is corneal scarring. The complication is corneal scarring. Okay, everybody? Corneal scarring, or I can say corneal opacity, and this leads to loss of vision. Okay, now this corneal scarring, this occurs due to trichiasis. Due to the cicatrization occurring, the eyelashes can turn inward, or due to the cicatrization, everybody, there can be cicatricial entropion that we have just discussed. Yes, so due to any of these two conditions or certain conditions like this, you can find corneal scarring. Am I clear about this, everybody? Yes or no? And that is the only complication, and that can lead to loss of vision or blindness. So trachoma, even though it is a conjunctival disease, but due to the fact that there is a lot of shortening, scarring, it can lead to loss of vision or blindness. Please remember this. Done? Now, what is the treatment of trachoma? What is the treatment of trachoma? So I hope you know that the treatment of trachoma is SAFE strategy, SAFE. Okay, this is taught in BSM also, everybody. S for surgery. What are we doing surgery for, everybody? What are we doing surgery for? Surgery for trichiasis. Surgery for trichiasis, yes, so that it does not rub onto my cornea, so that it does not cause opacity, so that the opacity does not lead to loss of vision. And A for antibiotics. A for antibiotics. Now, what are the antibiotics which are given, everybody? You can either give tetracycline eye ointment for 6 weeks, or basically what we prefer as the drug of choice is oral azithromycin, 1 gram. Okay, drug of choice. Then F for facial cleanliness. Why facial cleanliness? I hope you understand. The transmission is FFF. So if we keep our eyes and face clean, the transmission is stopped. And E for environmental hygiene. Again, if there is environmental hygiene, the flies will not be there. Okay, transmission. Okay, everybody. So this is SAFE strategy for your treatment of trachoma. Okay, everybody, done. No confusion about it. Now, the treatment is indicated based on the prevalence, everybody. Okay, so if active trachoma prevalence is greater than 10% in children 1 to 9 years of age, okay, everybody, then we have to do mass prophylaxis. Then we have to do mass prophylaxis. Then we know that it will become an endemic or an epidemic. Secondly, everybody, if it is below 5%, if below 5%, okay, then we are not actually worried. Okay, then we say only F and E done. For the community at large, we are talking about. Okay, no, we are not talking about the case, everybody. For the specific case, you will obviously need to do surgery and antibiotic. But for the community at large, everybody, if it is greater than 10%, then we will do mass prophylaxis in all the children. But if it is below 5%, then mass prophylaxis is not necessary. Only facial cleanliness and environmental hygiene should be advocated to everybody. Done, everybody? No confusion about this. I hope this is all about trachoma and you are clear about it and you understand trachoma very well now. Okay, everybody? Done. Now we move on to the other condition that we needed to discuss, everybody, as part of chlamydia, that is ophthalmia neonatorum. Ophthalmia neonatorum. Okay, ophthalmia neonatorum. So what is ophthalmia neonatorum? Neonatorum means neonates. Neonates means 4 weeks. Okay, 28 days. Ophthalmia neonatorum is basically conjunctivitis within 4 weeks to 28 days of birth. So conjunctivitis in a neonate is ophthalmia neonatorum. Am I clear to everybody? So what will there be, everybody? The main thing we see is clinical feature. In this case, we see is discharge. There is a lot of discharge coming out from the child side. Now, ophthalmia neonatorum is caused by chlamydia, yes, but it is caused by various other causes. Okay, so depending on the onset, we can tell us the cause. So if the onset is in within 6 hours after birth, okay, everybody, then what is the cause? Then if it is 24 to 48 hours, that is the first 2 days basically. Okay, within the first 2 days. Then if it is after 2 days, 2 to 5 days. Then the last is if it is 5 to 7 days, or if it is in greater than 1 week. Okay, everybody. So onset after birth. If it is within 6 hours after birth, then the cause is chemical. Which chemical, everybody? Which chemical? You will understand the dichotomy later on. If you know this silver nitrate, if you know something called as the Creed's method, you will understand the dichotomy. 24 to 48 hours. The answer is Neisseria. Which Neisseria? Gonorrhea. 2 to 5 days. Other bacteria. When I say other bacteria, I mean to say bacteria other than Neisseria. 5 to 7 days. Herpes simplex virus type 2. And greater than 1 week, what we are studying here, chlamydia trachomatis D2K. Okay, everybody. So these are the causes based on the onset. Okay, you will usually find that this is given jumbled up in a lot of books. Parsons will give you something else. Corona will give you something else. Some other will give some other book will give you something else. I tried to collate all the information, present everywhere, discussed it, and then presented it to you. Okay, so this should be very good for all the entrance examinations if asked. Okay, now please remember that the most common cause of ophthalmia neonatal is this. This is the most common cause. That is why I've taught you as part of ophthalmia neonatal as part of chlamydia trachomatis or trachoma. But the most severe manifestation is if somebody gets infected by Neisseria. Okay, everybody, that is the most severe manifestation, but the most common cause is chlamydia trachomatis greater than 1 week in presency. Am I clear, everybody? Yeah? No. See, if it has occurred, if you ask me what is the treatment of ophthalmia neonatal, then the treatment is specific to the cause. If it is due to chlamydia trachomatis, then I will have to, give the drugs azithromycin, tetracycline. If it is due to Neisseria, then I have erythromycin or ceftriaxone. If it is due to herpes simplex virus, then I have to give acyclovir. So the treatment depends on the cause. What is important is at the time of delivery or just after delivery, prophylaxis. We don't want this to occur. That's the main thing. Yes, we don't want to be able to treat it. We should be able to prevent it after birth. Prophylaxis. So in earlier days, prophylaxis was done by something called as Creed's method. Creed's method used 1% silver nitrate. I hope you understand the dichotomy. So earlier we said that silver nitrate is used. As soon as the child is born, apply 1% silver nitrate to prevent ophthalmia neonatal. But soon it was discovered that silver nitrate was itself causing chemical conjunctivitis if silver nitrate was expired or something like that. Okay, everybody? So Creed's method was shelved. Now, these days, what is the choice of prophylaxis, everybody? These days, the choice of prophylaxis is 0.5% erythromycin or 1% tetracycline. Okay. So this is the current method. Okay. Ointment applied within 1 hour of birth. Am I clear, everybody? Now, okay. What can also be done is povidone iodine. So in modern setups, we don't use erythromycin or tetracycline. Povidone iodine application is done to clean. But in rural setups, it is still advocated that we use erythromycin or tetracycline to prevent ophthalmia neonatal from occurring. But please remember, Creed's method is no more done. Creed's method itself became the cause of the earliest onset within 6 hours. Okay, everybody, done. And that's all about my ophthalmia neonatal. Now we are left with our last condition, everybody. Our last condition is allergic conjunctivitis. Okay, guys. Allergic conjunctivitis. Now, allergic conjunctivitis due to allergy, nothing difficult here. Okay, in allergic conjunctivitis, what is seen is papilla. Again, you know. Plus, what kind of discharge, everybody? Watery. This you should know. This you should be able to remember from the table. You should be able to see that table as soon as you close the eyes. Papilla with watery allergy, papilla with mucopurulent bacterial, follicle with watery viral, and follicle with mucopurulent chlamydial. Okay, please be able to remember that table. Now, the hallmark of all the conditions is in allergy. The hallmark for all allergic conjunctivitis is itching. So if the patient is presenting with all the symptoms, redness and foreign body, everything, but the patient is also saying, sir, I have a lot of itching, I need to rub my eyes continuously, then you're almost sure that the conjunctivitis will be allergic. Okay. Now, the main condition in allergic conjunctivitis, everybody, is what we call as vernal keratoconjunctivitis. Vernal keratoconjunctivitis, VKC. VKC is also known as spring catarrh. Okay. It is also known as spring catarrh. Am I clear to people? Now, VKC occurs more commonly in boys. That means the male sex is more prone to it. And when I say boys, I am trying to indicate the age group 5 to 15 years of age. I'm not saying a male adult. Okay, everybody? Then it has characteristically which type of hypersensitivity? Type 1 hypersensitivity. Type 1 hypersensitivity. And it occurs more commonly in summers. It presents more commonly in summers, and atopy is present. So other atopic diseases can also be manifested in the same patient. Okay, everybody. So vernal keratoconjunctivitis. This is a very important condition. This is what we are doing first. Now we know the basic etiological points. Now after these basic etiological points, let me move on to the clinical features here. Okay, everybody. Clinical features. Clinical features of VKC. Yes or no? Clinical features of vernal keratoconjunctivitis. Please remember. Please focus on the name. It's vernal. It's not venereal disease. It is not a venereal disease. I'm not saying venereal. Please. A lot of students just remember venereal, and then in third year 5 actually they say it's a venereal disease, so it's an STD. It's sexually transmitted. Please, it has nothing to do with sexual transmission, guys. It is an allergic conjunctivitis. It is vernal, not venereal. Okay, everybody. Now, VKC, what does it present with? First of all, it presents with watery discharge, but the discharge is actually sticky. Watery discharge is, I can say, ropey discharge. Ropey discharge. Okay, ropey discharge. Ropey discharge is basically what? Please remember this word, that even though there is no mucus, there is no pus, but the water is sticky. So when you try to remove the water, it will stick slightly. Okay, everybody. So ropey discharge. Now, Second sign is cobblestone papilla appearance. The papilla are so large, there are giant papilla, I can say. The papilla are so large, okay, that it looks as if they are like cobblestones which are arranged on a pavement. I hope you have walked on the pavements, everybody, footpath or pavement, everybody. Footpath mein patthar ek design mein lage hote hain, yes or no? In conjunction with each other, and that is what the appearance they give. Cobblestone papilla. Okay, everybody. I hope there is no confusion between the name, everybody. Cobblestone or pavement papilla. Then at the limbus, you see something called as Horner Trantas dots. Horner Trantas dots. This is at limbus. Why am I specifying at the site again and again? If you remember, at limbus in trachoma also we had seen something. In trachoma at limbus, what we had seen, everybody, in trachoma at limbus we had seen Herbert pits. So this was in trachoma. There were depressions, gaddhas or pits. But in now VKC or vernal keratoconjunctivitis, I am saying there are Horner Trantas dots. What are Horner Trantas dots, everybody? So Horner Trantas dots are deposits of eosinophils. Deposits of eosinophils. Eosinophils, I hope you understand that they are manifested in type 1 hypersensitivity. So if you want to differentiate between the photographs, I hope they will be very easy to differentiate. Let's see this photograph on your screen, and this should be an easy photograph now. Again, everybody, sclera, cornea. Where is the abnormality you see, everybody? Do you see the limbus? Do you see gelatinous or eosinophilic collections, everybody? Dot-like collections, everybody? Yes. Are you able to differentiate? Are they pits? Gadde bane hue hain kya? Nahi bane hue. They are collections or dots. So this is my Horner Trantas dots. So these are my Horner Trantas dots at limbus. Okay, I hope you will do good to remember this. Horner Trantas dots at the limbus. Done, guys, everybody. Now let's move back, everybody. What are the other signs? So the other signs, everybody, I will say D. D is something called as pseudo gerontoxon. Pseudo gerontoxon. So this is basically like Arcus senilis. Like Arcus senilis. Okay, like Arcus senilis. What was Arcus senilis, everybody? I had shown it to you today morning, if I remember. Yes, when I had completed the chapter cornea, everybody. Arcus senilis was what, everybody? Paralimbal, around the limbus, a whitish band due to deposition of lipids. Yes, so pseudo, it is looking like that. Gerontoxon, because it is looking like a condition which occurs in old age. Pseudo gerontoxon. Then the next thing is on cornea, you can see an ulcer, shield ulcer. Shield ulcer. Okay, everybody, also called as Tobbe's ulcer or Tobbe's ulcer. This can lead to loss of vision. Okay, everybody, obviously there is an ulcer, so this can lead to loss of vision. Now, the other signs, everybody, I'll just move on, everybody. F. The other sign, another sign is called as Denny Morgan line. Denny Morgan line. Denny Morgan line is an extra lower lid crease. Just like we have upper lid crease, we have a lower lid crease also. See my lower lid, everybody? Yes, we have a lower lid fold or a lower lid crease also. Can you see? So in this case, there will be an extra lower lid crease. Instead of one lower lid crease, there will be two lower lid creases. Then there is something called as Maxwell-Lyon sign. If you see cricket, everybody, these are the names of two Australian cricketers, Glenn Maxwell and Nathan Lyon. Yes, so Maxwell-Lyon sign. This is pseudo membrane formation. Pseudo membrane formation. Then please remember that keratoconus is more common. I think I had told you this in the keratoconus also today morning. See, why does keratoconus become more common? Because of the itching, the child keeps on rubbing the eye. When you are rubbing the eye, you are constantly basically putting pressure on the cornea and you are changing the curvature of the cornea. So you will always rub like this. You don't rub like this. No? ऐसा नहीं होता ऊपर नीचे. You rub like this. ऐसा rubbing करते हो. When you keep on rubbing like this, you are providing horizontal pressure from both the sides. So you are making your cornea cone shape. Okay, everybody? So keratoconus is more common in this. Now, what is the treatment? So the treatment of this condition obviously is what, everybody? Number one, histamines. Number two, mast cell stabilizers. I hope you understand this is an allergic condition. So I am giving anti-allergics. Yes or no? Topical, obviously topical. But if you ask me what is the drug of choice? So the drug of choice is olopatadine. Olopatadine is 1+2. Yes or no? Olopatadine is a mixed not histamine, sorry, antihistamines. My mistake. Thank you, Sanjay, for giving me the sign. I'm so sorry, I just said it in quickness of my completion. Antihistamines and mast cell stabilizers. So olopatadine is an antihistamine along with being a mast cell stabilizer, and that is the drug of choice. Okay, everybody? Or you can give any of the other ketotifen, azilastine, pepilastine, alcaftadine. Any of those can be given. Please remember, topical steroids are always given as primary therapy. Okay, so in this type of conjunctivitis, that is allergic VKC, in none of the other conjunctivitis we will need to give steroids, bacterial, viral, chlamydial, none of that. But in allergic conjunctivitis, you always need to give topical steroids also along with it. So initially you give topical steroids, and as the olopatadine and other drugs start to take effect, you taper down the steroids. Okay, everybody? So please remember, anti-allergic plus steroids are always given as treatment for vernal keratoconjunctivitis. Am I clear, everybody? Done. We are left with some more topics in conjunctivitis, everybody. I will do them in the next session tomorrow. So tomorrow, no, not tomorrow, I think day after tomorrow now. So day after tomorrow, that is on the 26th, everybody, we will complete our conjunctiva. So we have topics, certain topics like pterygium and such left. and then we will move on to UVR. Okay, everybody. So this is what will be done on 26th. I hope to find all of you there. That will be the last session of our complete course of ophthalmology part 1, everybody. As I've already said, everybody, so 26 is the last session. As I've already said, I would hope that all of you give time and all of you revise from lesson 1 to lesson 26 that we have already done before the last session comes, so that if there is any doubt, you can ask me a question also. As always, everybody, please feel free to ask me any doubt that you may have on my Facebook. If you are not being able to ask me a doubt here, the Facebook page is, or the Facebook group is UB Ophthalmology